Hello, my name is Dr. Appel from Ado Psychology Center, where we specialize in treating anxiety, depression, and OCD. Welcome to our video seminar series. Hope you enjoy this video. So this video is going to be about panic disorder, which is considered one of the anxiety disorders in the DSM. The goals for this video are for you to get a better understanding of panic disorder and to learn about treatment. So before we get into panic disorder, we need to discuss briefly what a panic attack is, because people can experience panic attacks, and often do, without developing panic disorder. But in order to be diagnosed with panic disorder, you must be experiencing panic attacks. So what is a panic attack? A panic attack is an abrupt surge of intense fear or intense discomfort, with four of the following symptoms being present: palpitations, pounding hard, accelerated heart rate, so increased heart rate, sweating, trembling or shaking, sensations of shortness of breath, feelings of choking, chest pain, nausea, feeling dizzy or faint, experiencing chills or heat sensations, tingling sensations, feelings of derealization or depersonalization, so feeling as if things are unreal or being detached from yourself, which is very hard to describe if you haven't experienced it, but it's something like you really feel like you're almost as if you're in a movie and you're seeing what your body's doing, or you're seeing and hearing people around you, but you're kind of in a trance in a way, if that makes sense. Fear of losing control or going crazy, and fear of dying. So if you have four of these symptoms and it's an abrupt surge of intense experience, that's likely you experiencing a panic attack. The reason I put specifier at the top of the slide is because many disorders oftentimes are accompanied with panic attacks. So someone can have PTSD, post-traumatic stress disorder, with panic attacks. So it could be a specifier for other disorders, or it could just be a panic attack that you experience kind of out of the blue, an unexpected panic attack. But this does not yet mean that you have panic disorder. In order to meet criteria for a panic disorder diagnosis, you need to experience recurrent, which means at least two, unexpected panic attacks, which means it seems as if it's coming out of the blue. Now, after the fact, you may tie it to a specific reason, but in the moment, it feels like it's coming out of the blue. So if you're really scared of needles and you are at the doctor's office and you have a panic attack before you're about to get a shot, so that would not be considered unexpected. That would be expected. But if you're kind of minding your own business at the mall and all of a sudden you're experiencing a panic attack, that's considered unexpected. After you're experiencing these panic attacks that are unexpected, you then are constantly worried about when is the next panic attack going to come. Or you're constantly worried about the consequences of these panic attacks. Does this mean I'm going crazy? Am I losing control? Am I going to be having a heart attack? So this is the main distinction between just panic attacks and panic disorder, where panic attacks are just the attacks, and they happen to a large portion of the population, we'll talk about it soon, versus panic disorder, which is when you've experienced a panic attack and you're really scared of experiencing another one. And these panic attacks are completely unexpected. If you're not really worried about having another one, but you're changing your behavior in such a way that you know you're going to be avoiding them, so yeah, you're not worried anymore because now you're only staying home all day, or you're only staying in bed where you feel like you won't be experiencing a panic attack. So if you're engaging in these types of avoidance behavior to not have a panic attack, that would be another way to meet criteria for a panic disorder. So let's talk about some statistics. Lifetime prevalence of a panic attack is approximately 35%. So a significant portion of the population, right, a third, and maybe even more than that, by the way, but at least this is what's reported, experience having at least one panic attack at some point in their life. So it's not that uncommon. And yet, the lifetime prevalence for panic disorder is only about 5%. So only about 5% of people in the population experience panic disorder at some point in their lives. Prevalence is low before age 14. You don't really find panic attacks much in children. Female to male ratio is 2 to 1, so it's twice as common amongst females and males. And 25% of people with panic disorder report suicidal thoughts. So again, you can imagine how distressing this disorder can be if it's causing people to start thinking about suicidal thoughts. So what are some therapy options for panic disorder? Well, there is cognitive behavioral therapy, there is acceptance and commitment therapy, or a combination of both. Now, of course, there are other therapies out there as well, but these are the ones I'm going to be discussing here in terms of the therapy options for panic disorder. So let's discuss CBT, cognitive behavioral therapy, first. So let's discuss the general CBT conceptualization, and then we'll apply it to panic disorder. If you want to learn more about CBT, check out my other video, which is on CBT more broadly. But here I'm going to be applying it specifically to panic disorder. So, as we've discussed in the other video, what you think and do affects the way you feel. That's the main slogan, you can say, for cognitive behavioral therapy. And so when it comes to panic disorder, it's no different, where your thoughts and your behaviors are affecting and impacting your disorder. And if we can change your thoughts and behaviors, we're likely going to bring you some relief from panic disorder. So therapy usually starts with psychoeducation, which is just a fancy way of saying, providing the patient with information related to their disorder. So panic disorder is often referred to as fear of fear. Because if you think about it, what the person is afraid of are these panicky symptoms, which are fearful symptoms. And they're so afraid of the fear that they kind of trigger the fear in a way. So in short, we have this cycle over here where someone experiences a panic attack, which then causes increased physical arousal and worry about another attack because it's really uncomfortable. And they're like, I don't want to have this again. And so I'm going to keep, their body's more aroused for being prepared for another one, which leads to vigilance of bodily symptoms. So the person now is being extra vigilant and like checking with their body the whole time. Like, am I feeling okay? Do I feel a little bit faint? Is this small physiological experience going to now trigger or turn into a full-blown panic attack? That leads to catastrophic misinterpretation of physical sensations. So saying like, oh my God, I think it's coming. I think I'm about to have a panic attack. And then boom, what do you know? Panic attack occurs. And so the idea here is our bodies are meant to fluctuate a lot. You may at some points throughout the day feel a little bit of an increase in your heart rate. You may sometimes feel a little bit weaker and sometimes stronger. You may feel dizzy for a moment. But if you just kind of ignore the symptom and it doesn't keep coming back, you're fine. But in panic, people tend to become hypervigilant of all of these symptoms. And then the more vigilant and scared they are, the more likely it then turns into a full-blown panic attack. So there's a good example here of two hikers are going for a hike in the woods. One hiker runs into the park ranger, who warns her that a bear has been spotted in the woods. The other hiker does not receive this warning and continues on his way, enjoying an afternoon hike. If he hears a rustling in the woods, he assumes that it's a squirrel or the wind. The hiker who is told about the bear, however, is very cautious and constantly on the lookout for the bear. She becomes sensitive to anything that suggests the bear is near, for example, rustling in the woods, and might decide to avoid the woods altogether and not return to the park. This is what happens when you have a panic attack. So this is an example of psychoeducation we provide to a patient. Because you've been alerted to it, you might find yourself always on the lookout for another panic attack. This can make you feel nervous, which might lead to another panic attack. You might even start to avoid things that remind you of the attack. So imagine you're in the woods here and you hear rustling of the leaves. It doesn't really bother you, but if you know there's a bear somewhere there, you're going to be hearing a lot more rustling of the leaves, and each time you're going to have a catastrophic misinterpretation of it by saying, oh my God, that must be the bear. And this is a great example for what it feels like when you have panic disorder. So one component of psychoeducation is to discuss the fight or flight response, which refers to this built-in process that our body is hardwired for to help us protect against a threat. So, for example, if a bear really is coming at you and you have to run away really fast or fight really hard, our body is hardwired to have our sympathetic nervous system go into overdrive, which causes all of these physiological sensations of a panic attack. And so we spoke before about the catastrophic misinterpretation of these symptoms. So this component of the treatment is to help patients, instead of misinterpreting them, being able to interpret them in an accurate and positive light. So when they're noticing, for example, that their vision is going blurry, instead of saying, oh my God, I'm going crazy here, or I can't see straight, they can recognize that the vision can become acute so that more attention can be paid to danger. And so it may seem like tunnel vision or might be more blurry for some reason. But the point is, these, your body is doing this to protect you. It's not a harmful or threatening message. It's rather one that's here to protect you. Dry mouth, part of the digestive system, so digestion shuts down during these situations so that energy can be diverted towards the muscles. So when someone's experiencing dry mouth, again, instead of feeling like this is really bad, this shouldn't be happening, they could tell themselves like, okay, this makes sense. My body has a false alarm triggering the fight or flight response. So now my whole body's going to feel kind of weird, but it's ultimately there to protect me and I have nothing to worry about. So now that we discussed the psychoeducation component, let's jump into the cognitive and behavioral skills part of the treatment. So for cognitive skills, we have cognitive restructuring, which can include identifying distortions in thinking, generating more accurate thoughts. We have behavioral experiments as part of the treatment. We have exposures as well as part of the treatment. And the exposures for panic disorder are referred to as interoceptive exposures. And I'm going to be talking more about each of these components on the coming slides. So let's start with cognitive restructuring. For cognitive restructuring, you want to be able to identify some of the distortions. So for example, here, it may be mental filter, maybe jumping to conclusions. So for example, if you're experiencing these symptoms and you're jumping to the conclusion like I am going to have a panic attack, I am dying, right? Or maybe only paying attention to the evidence that you're going crazy without reminding yourself like, no, this is what my body's supposed to be doing as part of the fight or flight response. So you could identify these cognitive distortions and then try to restructure your thoughts so that they're more accurate. So you could tell yourself, okay, I am safe. This happened to me 100 times before. This is not a heart attack. It's just my body getting a false alarm for the fight or flight response, which is ultimately there to protect me. So I'm just going to sit through it. So this is the cognitive restructuring component. If you want to learn more about cognitive restructuring in general, I suggest you check out my video on CBT, cognitive behavioral therapy more broadly, where I go into a little bit more detail than here. But as you can imagine, that's how cognitive restructuring can be applied in panic disorder. So another skill I mentioned was behavioral experiments, which sounds like a behavioral skill, but really it's more of a cognitive skill, and I'll explain to you why in a moment. But in short, over here, you have someone test their beliefs as if they were a scientist. So perhaps the belief is if I leave the house without water, I am, if I leave the house before I eat breakfast, I'm going to have a panic attack. And not only that, but it may actually be a heart attack. I'm going to die. And so you have the person put that hypothesis to the test. And you say, okay, so for the next couple of days, every day you leave the house without eating breakfast, and we'll see what happens. So one of two things might happen, right? They're not going to die, that we know already. But one of two things might happen. One is where they don't experience panic attacks, and we say, okay, so you kind of disproved what you said that if you go out without eating breakfast, you're going to have a panic attack. And number two, and this is valid, this is why it's a cognitive skill, because this then provides information for the future, changes their thinking about their behavior and and their predictions of what might happen. So then going forward, this can help with a cognitive restructuring piece where they have to remind themselves like, okay, I'm nervous of having a panic attack, but I've tested this and I didn't have one, so I'm not for sure going to have one. The other outcome might be where the person has a panic attack, which might be the better of the two outcomes, but they don't die from it. And then again, the experiment shows that even if you have a panic attack, you could survive. So behavioral experiments could be really powerful and really proving in a solid scientific way that whatever the fears are irrational and don't actually occur. So now we're getting up to the exposure component. And before engaging in exposures, you might have a client fill out a panic attack record, which is where they list the symptoms that they tend to experience during a panic attack and how severe they are. Because based on their symptoms, that's going to determine what type of symptoms we need to expose them to. And this is why it's called interceptive exposures, because these exposures are not really so much to situations, although you could also have situational exposures where they think they're going to have panic attacks. But interceptive exposures is exposing them to the feared bodily sensations. So if, for example, one of the feared symptoms is dizziness or feeling faint, you can have them make themselves dizzy. They could spin around in a chair. They can shake their head rapidly from side to side for 30 seconds and then feel dizzy or feel faint. So here's an example on the slide of all different exercises and what the evoked physical sensation is, to the point where if they do this enough, the fear against feeling dizzy is going to start dying down. And so the next time they might start experiencing, a dizziness feeling, instead of immediately telling themselves, I'm going to have a panic attack and I can't handle this, they'll just be like, okay, I'm used to this sensation because I've been doing these exposures. So that's how interoceptive exposures can help for panic disorder. So that was a lot about CBT, cognitive behavioral therapy. Now let's talk about ACT, acceptance and commitment therapy. And again, for more information on ACT, check out my video seminar on ACT more broadly. But here we're just applying ACT to panic disorder. So in ACT, it's all about psychological flexibility and getting there through having values, like identifying your values, engaging in committed action in line with your values, and not being, dissuaded from your path in life by thoughts, not by changing them as in CBT and fighting them, but rather by changing your relationship to your thoughts and acceptance of your feelings. So if you're feeling a certain way, you have emotions that are distressing, instead of trying to change the emotion, just making room and space for them and accepting them. So when it comes to panic disorder, very briefly, what we'll do is we'll have the person identify their values in life and what committed action looks like within line with their values. So for example, if one of their values is being a great parent to their kid, and now because of the panic attacks, they're not taking their kid to the park, let's say, or wherever it might be. So engaging in committed action would mean to go to the park because that's in line with your values. And then when you have thoughts like, oh my God, I'm having a panic attack, instead of trying to restructure it and change it and prove why it's wrong, just change your relationship with those thoughts. So you can kind of make a joke about it, or you could use any of the cognitive diffusion skills that we spoke about in the other seminar on ACT to kind of change your relationship with these thoughts so that you're not fused and attached with these thoughts, but you can experience them just as what they are, which are thoughts. You can say, like my mind is sending me this thought that I'm having a panic attack. Thank you, mind, for that thought, whatever. It's just a thought. And so through the ACT model, I know for people who are not used to ACT, this all sounds kind of like fishy, but ACT can definitely help a lot when it comes to panic disorder and other disorders. And for more information, again, check out the ACT video so you'll learn more about it. And then acceptance, making room for these feelings, making room for the physiological sensations. Psychoeducation could help here too, because it can be easier to accept once you understand what's going on in your body. But when you're feeling a certain way, you're feeling dizzy, you feel like you might have a panic attack, you can take a moment, take your breath, and just say like, okay, I'm accepting these feelings. I'm making space for them. Let them come, let them go. I know what my values are. I know what my committed action is. I'm still going to the park no matter what. And I'm going to go on living my life. Ideally, though, you might want to try combining CBT and ACT. So you can do cognitive restructuring from a CBT perspective, changing the thoughts, recognizing them as irrational, and coming up with more rational, appropriate thoughts. You could engage in cognitive diffusion from an ACT perspective, where instead of fighting and getting in the weeds with your thought, you just change your relationship to your thoughts to the point where they become kind of meaningless. Because if you don't give them value, then they are some intangible thought that you don't have to pay attention to or really deal with. You can keep in mind your values and committed actions. So even though that's more of an ACT approach, in CBT, it can help you engage in the therapy and do the exposures when you feel like you're heading towards somewhere and there's some purpose to all this. So having values can be really, really helpful, and making this commitment to act in a certain way in line with your values. Interoceptive exposures is more of a CBT skill in that way, but it fits very neatly into ACT as well because committed action in ACT, again, can include exposures because you're committing to action that's in line with your values. And if your values are to be able to live a functional life and panic disorder is getting in the way, so engaging in interceptive exposures itself can fall into the category of committed action within ACT. Acceptance of physiological and emotional responses can be super helpful, even though that's more of an ACT thing, but it could definitely apply to CBT as well. And we're kind of doing that with the psychoeducation of recognizing this is all a fight or flight response. Your body's supposed to be doing this. So just live with it and it's okay and don't feel alarmed by it. Just make room and space for it until it passes. There's a DBT skill called riding the wave. That's dialectical behavior therapy, not to confuse you completely, but riding the wave is can be looked at as another way of acceptance and dealing with these intense physiological sensations that occur during a panic attack. Staying in the present moment, which again is a ACT component, and self as context also as an ACT component, which is a bit hard to describe, but in short, it's kind of saying like you're the chessboard, you're the playing field where all this is happening. It's also being kind of metacognitive, recognizing what is going on inside you without being attached as if you're in the moment, but instead you become this observer of your experience. So I know all this is a little bit convoluted or complex because we're speaking about ACT and DBT and CBT, but I just wanted to throw in these other components so you get a feel for what it might look like to have a multimodal approach to treating panic disorder, because why stick with one approach when you could borrow from other approaches to get a better response. And again, for more information on the other disorders, check out those videos where things might become a little bit more clear after you see those. So to summarize, panic attacks are fairly common and no big deal. And if you treat them as such, as no big deal, they likely won't become a big deal and they won't develop into panic disorder. Panic disorder prevalence is about 5% lifetime prevalence, so 5% of people experience panic disorder at some point in their life, and it could become debilitating. Treatment includes both CBT and ACT, or a combination of both, where you can use cognitive skills, behavioral skills, acceptance skills, as I mentioned during the presentation. And last but not least, the therapist can help you tailor treatment for your specific needs, maybe help guide you within the CBT approach, within the ACT approach, or borrowing from different modalities to make a unique recipe for your specific needs. Hope you enjoyed this video seminar. To see a full list of our current videos as well as upcoming videos that we'll be posting soon, visit us at adopsychologycenter.com and sign up to be notified when we post new videos. Bye for now.